Everyone, I am so happy to introduce today. We have two expert speakers to tell us about occupational therapy. Dr. Sarah Foidel is currently serving as interim director of the School of Occupational Therapy at Pacific University in Oregon. Dr. Foidel's research and clinical practice interests include neurologic conditions, dementia, functional vision, and functional cognition. Dr. Gina Tucker-Roghi is also speaking today. She serves as an associate professor and the chair of the Occupational Therapy Department at Dominican University of California. She brings over 30 years of expertise in geriatric clinical practice, leadership, and education to her role. And Dr. Tucker-Roghi is board certified in gerontology through the American Occupational Therapy Association. You can see that they have tremendous expertise to share with us on partnering effectively with occupational therapists in primary care. Welcome.
Thank you. We're going to get started, and thank you so much for being here. We're going to talk with you and hopefully answer all your questions about partnering effectively with occupational therapists in a primary care setting. We hope to today expand your knowledge of the breadth and the depth of what occupational therapists can do for aging adults. Here are our objectives. And we're going to start out with really looking at what is the scope of occupational therapy. We are imagining that within the audience, people have varied experiences with our field, as we want to make sure everyone has an understanding of our scope. Looking at our scope of practice then and how it aligns very strongly with the 4M framework. You will learn about the occupational profile. If you are not familiar with that, that is a requirement of all OTs to do every time we do as an assessment. And it really speaks to that what matters part of the M's. Understand the 5 opportunities for the top 5, I should say. We have many opportunities for occupational therapy to provide age-friendly care to older adults. And looking at a way to create age-friendly referrals for older adults to receive occupational therapy services. What is occupational therapy? I hope no one in the audience is saying that, but just in case you are in your head, we're going to back up a little bit and look at our profession. We are 2 things we are not. We are not helping people get jobs, though sometimes we do, but that's not the main part of our career. The other thing is we're not kind of like physical therapy, but for the upper body. Those are 2 things you will hear out there that we want to get rid of those myths. When we talk about occupational therapy, the heart is the occupations. Defining occupations as activities people need to do and want to do to take up their time, those meaningful activities that bring us purpose, connection with our community, and meaning to our lives. We help people across the lifespan from the NICU to hospice care. And you'll see this will be a theme on the next few slides, looking over, we look not only at the person, their skills, overall the environment. What does the environment provide? Does it support or not support? And then the demands of the occupation. Particularly occupational therapy and productive aging has a very strong role. Occupational therapy sort of tackles challenges in a very hands-on and practical way. So not teaching people what they should do, not taking away occupation if someone is no longer safe or does not have the physical capabilities. We focus what's really happening in real life, and can we change some skills? Can we adapt some occupations and so that people can continue to engage? It's also very collaborative. Back to that, what matters. Definitely working with older adults and productive aging is not something we can look at as a recipe card in the way of what does someone feel is productive aging? What does someone define as their home? What does someone define as what is meaningful? And so we can make a workable plan for everyone involved. Occupational therapists look at activities, and as I mentioned, environments. We'll have a lot more specific referral information and specific examples later in the presentation. But how can we change activities? How can we remove challenges or barriers so that people can participate? And at the heart of it all, we are very holistic. So we are not focused just on physical, just on cognitive, just on mental health, just on sensory, but how that whole picture goes into how someone functions and how they can function within the environment. Being part of the rehabilitation sciences or the rehabilitation field, I think this first bullet point of our scope of OT is something that people think about right away. If someone is aging, develops a condition, maybe a neurologic disorder, a chronic condition, rehab by definition is basically improving those skills, returning someone to a baseline. So yes, this does happen with older adults, but OT has so much more to offer, and we are not stuck in that box of, well, for example, someone has cognitive decline. Well, they can't be in rehab because they're not going to make progress. Maybe not for their cognition, but they absolutely can make progress in their ability to engage in everyday activities. So we can look at other things, environmental modifications, down to simple equipment, to assistive devices, what we call low tech, one-handed techniques, to home modifications, grab bars, other safety equipment. Looking at health promotion is really looking at that proactive. It's more than preventative medicine. It's promoting all the health management and all those healthy occupations that support people aging successfully. So anywhere from engaging in physical activity to making sure people have access to nutrition. And we'll talk a little bit more later about medication management and what that means in the realm of OT, because we're not prescribers of medication, but we definitely have a role in how someone safely takes their medication. I mentioned assistive tech. Family and caregiver support is a huge role for anyone working in productive aging and age-friendly health systems. Do the caregivers have access? Is the education being provided at a health literate level? And back to environment. Sometimes our caregivers and our families are one of the strongest components of our environment that can be supportive or not so supportive without the correct education. Lastly would be community reintegration. So are we helping build skills, collaborating with older adults so that they can facilitate participation in community activities, senior centers, book clubs, so all the social occupations, and really looking at what barriers is keeping an older adult from engaging in their community. I'm going to pass it to Gina.
Thanks, Sarah. Appreciate it. Well, hopefully you're already able to see some of the alignment here in what you've heard from Sarah about how occupational therapy kind of fits into this 4Ms framework. And I was so glad to see that Barbara opened us with a reminder of the 4Ms. So I think what we'll do at this point is take a look at what is the OT kind of lens when looking at the 4Ms. Sarah, you can move to the next slide. Thanks. So when we look at the 4Ms through the OT framework, one of the things I think that we have the most to contribute to is the what matters. And you'll learn a little bit more about how we look at individuals' daily routines, their habits, their values, their identity and valued roles, things that are important and meaningful to them. So while traditionally the what matters talks a lot about people's end of life choices, we're kind of looking at what matters to that person in their everyday life, and we find that that's really expressed in lifelong habits and in lifelong values and roles that we can see what matters to that person by looking, at what we call their occupational profile. When you look at mentation, occupational therapists are trained to really understand cognitive performance, to assess and evaluate cognitive performance and how that interacts with other areas of participation and function. So we're also looking at their self-perception of cognition, as well as their mood and some of the mental health factors as well, how those impact daily function, how somebody self-regulates their emotions, and how they may use compensatory strategies or self-regulatory strategies for both cognition and mood. For mobility, we're going to look at their current capacity for functional mobility, but also their assistive device use, their history of falls, how the environment may be a barrier for them at home, daily activities and routines that either support mobility and support people being up and active, or maybe that deter from that. As well as looking at community mobility and access. And then medications, where traditionally, I think the 4M framework, when we look at medications, we're talking about what medications and how much of different medications are people taking, and why are they taking them. But from the OT perspective, we will also be looking at their method of obtaining medications, how medications are stored and organized in the home. How do they remember to take their medications? Do they use a schedule, a pill minder, ability to open containers? So we're kind of looking at it from that perspective. So hopefully you'll continue to hear as we move through some different areas where OTs work in productive aging. You'll continue to see alignment with these 4Ms. Okay. So I wanted to talk a little bit about the components of the OT process, and what it is when we have an order to evaluate and treat or to intervene with somebody, what the steps of our process are. So we may start off with an initial consultation and screening to identify if our services are a good fit for somebody. And then we go through an occupational profile. And I referred to this a little bit, and I'm gonna, in a future slide, show you a template for our occupational profile that goes into more depth. But in addition to just a medical history, this is really kind of a life history for an individual that helps us to really understand those values and roles and preferences that are important to them. And then we move on to analysis of occupational performance, where we're looking at assessing how they actually engage in occupations like self-care occupations, leisure occupations, but we're also looking at the context, that environment piece. How is the context or the environment supporting engagement? And then we'll look at somebody's individual performance skills or their performance patterns. And the performance patterns are the routines and the roles and the habits that people have. And so we spend some time really looking at that and understanding how that is supporting or taking away from participation. And then we'll also look at client factors. The types of interventions that we might be involved in are health promotion, remediation or restoration or rehabilitation that Sarah mentioned. Sometimes we're helping people to maintain function or maintain engagement. We might be modifying or adapting, and we also focus on preventative type services. Oftentimes you'll see that the occupation itself, engagement in an occupation or in an activity, is our mode of intervention. So we are doing the thing with the person. But sometimes we're also using interventions that support occupations, things like modalities or orthotics or prosthetics, assistive technology, or that modification of the environment. So those are some examples of things we might do that support us in our ultimate goal of occupational engagement. We use education and training both for the client and caregivers, whether that be family caregivers or paid caregivers. And advocacy is a really important part of our process as well. The outcomes that we're targeting or the goals that we're after are sometimes, that specific occupational performance that they're going to improve their level of independence. But sometimes we're looking, as I mentioned, at prevention, health and wellness. Quality of life might be a targeted outcome for us. Participation in occupation, not just independence in it, but participation, ability to retain an important role or role competence for somebody, well-being, and occupational justice, which is the idea that people have the right to be involved in occupations and have access to meaningful occupations. Go ahead, Sarah, thanks. So I just wanted to highlight a skill that I think we bring to the interprofessional team that's fairly unique to us, which is our expertise in activity analysis. We spend a lot of time on this in school, really learning how to break down an activity, to look at what skills are specifically required to perform an activity or an occupation. What are the barriers to performance for that individual? How is that environment or context affecting their ability to participate? What might the cultural meaning or the values be that are ascribed to the activity? So we're really looking at breaking that down, and that sets the foundation for us to then say, okay, this person has a degenerative condition or a chronic condition that isn't going to get better. If I'm going to find occupational engagement for that person, I'm going to have to change the occupation. I'm going to push that occupation circle in. Or it's not an occupation I can change very much, but boy, I can change the environment to help it be more supportive of that person. I can reduce distractions in the environment. And so then we're pushing that environment circle in to get that alignment that we're looking for. We're always looking for that just right challenge for a person, where the environment and the occupation are a good match for what their capacity and what their capabilities are. So this is a template that our association, the American Occupational Therapy Association, has provided for an occupational profile. And if you look along the left-hand side, the purple sidebar there, you'll see that it has, let's see, let me pull mine up here. On the left, it says the client report. So this is us asking them, about their occupational history, their interests, and their values. And then further down is the context. So we're looking at how does the environment, either the physical environment or the kind of the personal context, either support engagement or inhibit engagement. So for each of those things, we're looking at how is this supportive or how is it potentially detrimental to engagement. And then at the top of the second page, we have performance patterns. I mentioned those are those habits and roles, routines, and rituals. How are they supporting an individual or inhibiting engagement? And then we look at their client factors, things like their body functions and body structures. So that's a little bit more of kind of that medical model piece. And then lastly, we're looking at client goals and organizing them around those outcomes that we just talked about of prevention and quality of life and participation. So this is a required part of any occupational therapy evaluation that's billed to Medicare using our CPT codes. Not everybody will use this format. This is a template provided to us, but an occupational profile is an essential part of every occupational therapy evaluation. So if you're looking for this information within your interdisciplinary team, maybe committees, and you're thinking, boy, it'd be good to know more about, that person's values or that person's performance patterns, reach out to the occupational therapists on your teams and partner and collaborate with them. So we're going to move now into a discussion of what Sarah and I thought, represented some really important areas where you might have an opportunity to partner with OTs in productive aging. So first, I'm going to talk about managing chronic conditions and how we support older adults in that. We are going to talk a little bit about dementia care and caregiver support, mobility, whether that be personal mobility or community mobility, aging in place and home modifications, and then mental health and social participation. And again, you'll continue to hear these themes that we've been talking about around how we intervene around the person, the occupation, and the environment. So first off, I was going to talk a little bit about OT's role in the management of chronic conditions. So one of the things that we'll spend a fair amount of our time in is trying to support that engagement in meaningful occupations. So these might be self-care occupations. Oftentimes, that is what we think of, with OT. If you've worked with OTs in the medical model, we think a lot about self-care and dressing and toileting and self-feeding, and those are important occupations. But so are leisure occupations and social occupations. So we'll be looking at how can we ensure that this person is still able to engage, supporting those habits, routines, and roles, participating in instrumental ADLs, things like meal prep and managing their household and medication management. How is that chronic condition impacting their ability in these areas? Health management is an occupation, so being able to manage their own health conditions. Fall prevention and home safety often comes up because of the the signs and symptoms that go along with many different chronic conditions, and then participation in driving and community mobility, and also how that might enable somebody to remain engaged in their community and integrated into the broader community. Okay, so some of the settings where you might see OTs working on, supporting somebody with chronic conditions, certainly in the acute care or hospital setting. Sometimes that person is there for, an acute exacerbation of their chronic condition, or potentially a new unrelated condition, but they have these multiple chronic conditions that we know many older adults have. We might also be addressing chronic conditions in the skilled nursing facility, because it's often the people who have multiple chronic conditions who do need that middle step of a skilled nursing facility before they return back home, or people who are living in the skilled nursing facility long-term and have chronic conditions that are keeping them from engaging in the community that is there in the facility with them. Certainly home health, PACE programs, the program for all-inclusive care of the elderly is a really excellent place for OTs to do our work, as well as community-based organizations that sometimes will employ OTs as well. There are some OTs that provide these types of services in outpatient clinics, although I will say that outpatient is more prevalent for OTs who work in pediatrics. It's a little harder to find freestanding outpatient clinics focused on geriatric care. Okay, so rehabilitation following acute exacerbation, we talked about that. Adaptive strategies to manage symptoms associated with specific chronic conditions. So this might be, somebody's has COPD and we're working on energy conservation or task simplification. Somebody's living with arthritis and we're working on pain management. So helping to incorporate those adaptive strategies into their daily routines. Also, the incorporation of the health management tasks that they need to do to manage that particular condition, modifications of activities and environments to support and promote function and participation, and then exploration of interests and occupations that align with the person's current context. Their current context might include where they're living now. Maybe they've moved to an assisted living. Their caregiver situation, their access to resources are all a part of that context. And they may no longer be able to access meaningful occupations because of changes in their context or because of changes in their level of function that are related to their chronic condition that they're dealing with. Sarah, next slide. Thank you. So here's a couple of examples of some potential cases. So Margaret's an 83-year-old cisgender female with heart failure who needs to record her daily weights and prepare heart-healthy meals. She is seen by a home health occupational therapist. So she may have a goal to incorporate energy conservation techniques into daily meal prep routines. Also, commonly when we see people with heart failure who have health maintenance behaviors that they need to incorporate, like recording that daily weight, we're going to take it that extra step from just putting it on a piece of paper as a patient handout and saying, here, you need to do this. We're going to look at, do they have the balance to stand on that little digital scale in their bathroom? Are they holding on to the bar because they don't have the balance to do that? Do we need to make a place for them to record their weight that's visible, that's going to cue their memory to do that activity? So we're going to get really practical with how is it that they're going to get this done and really integrate it into their daily life. We can look at Frank, who's a 72-year-old cisgender male who retired 8 months ago and is recently widowed. He lives with diabetes, low vision, and peripheral neuropathy, and he wants to increase his participation in leisure and social occupations. So he's seen an OT in a group wellness program that's offered at a community senior center, and is also seen the OT for some additional individual sessions. And so a goal for somebody like Frank might be to identify 3 leisure activities that align with his interests and address potential barriers to participation. And I would say that align with his interests, but also align with his current condition, the low vision that he's experiencing and the peripheral neuropathy. Okay, so we're going to move now to talk a little bit about OT and dementia care. So individuals living with dementia and their caregivers. This is an area of care, of course, where the care partner, the caregiver, is just as important of a part of the intervention as the individual living with dementia. So I mentioned previously that functional cognition is a really important part of what we do. So really understanding how that person's cognition is showing up in the midst of daily occupations, of activities, and kind of moving it outside of a verbal test or a paper and pen test.
Gina, I'm wondering if I can break in. There's a question that came up about the previous segment, and we
Sure.
can wait till the end if you want to get into this in more depth. But the question was, what are energy conservation techniques, and can you give some examples?
Yeah, thank you. So somebody who has a limited amount of energy because of their chronic condition, and they need to kind of use that energy wisely so that they're not exhausted and unable to do the things that they need and want to do. So a simple example might be for meal prep or cooking in the kitchen. Can they have a stool in the kitchen that they could do part of that task from a seated position rather than doing it from standing in order to conserve and save some of their energy? Can the kitchen be set up in a way that things are organized so that it's less demanding, less walking back and forth to get objects that they need? Things are stored in a way that minimizes energy demand. Yeah. Sarah, did you want to add anything to that?
No, I think you covered it pretty
Okay.
well. It's just, again, either changing the task or changing how the person does it. So
Yeah.
it's very individualized by occupational therapy, depending on the task.
Okay, thank you for the question. Okay, so moving back to folks with dementia and their caregivers that we might work with, functional cognition, assessing and really understanding their functional cognition, whether it be, what parts of their memory are still intact. Can we really tap into their long-term and procedural memories, even though they have some weakness in short-term and working memory? Understanding how their cognition interacts with daily activities, their ability to sequence tasks. So we're really looking at cognition embedded in those everyday tasks. And we want to really fully understand that so we can then modify the task or the environment to support them so that we can really bring out and tap into those remaining strengths and abilities that that person does have. Caregiver support and education is a really important part. And again, there's so much very good information about how to support people with dementia. And where we try to come in is to be that person who's in the everyday activities to see, well, how do I apply this long list of tips and suggestions? Which ones make sense with my loved one who's in this specific stage of dementia, in this specific environment that they live in? How do I apply these different strategies and techniques, and what's going to work, and practicing that together and problem solving it together. And then OTs will also have a role in looking at how the person is experiencing maybe the healthcare system or different community programs that they try to engage with. So an example in the healthcare system is, maybe somebody who is really struggling when they're in the hospital with the amount of sensory overload or sensory demands of the environment. And how can we make that environment more suitable for the challenges that person has? So some of the settings, again, acute care hospital is a common setting for us to be interacting with people with dementia. Skilled nursing facility, definitely. Home health, and again, that community-based practice or outpatient model. We may be involved in non-pharmacologic management of neuropsychiatric behaviors, looking at how can we modify, oftentimes it's sensory aspects of the environment that are triggering behaviors. So we can look very carefully at how that might be contributing. Prevention and management of delirium. So by engaging people in meaningful occupations while they're in the hospital, for instance, or helping to manage sensory aspects of the hospital environment, we might be able to help them to be more oriented. Engagement in meaningful social, self-care and leisure occupations. So again, this is where we've really got to find that just right challenge or that just right fit for that person. So people in all stages of dementia have the ability to be engaged at some level if we can get the task demands right. And so we're looking at, rather than somebody sitting passively and not having the opportunity for engagement, can we simplify the task? We talked about functional cognition, caregiver education. Yeah, I think we've spoken of most of those. So let's move on, Sarah, and I'll take a look at the examples. So Ruth is an 83-year-old cisgender female living in a SNF. She's been losing weight and is becoming increasingly resistant to care with episodes of aggression. She was referred to OT by the behavior committee at the facility to trial non-pharmacological approaches to managing her care. An example goal might be the client will perform oral care standing at the sink without physical aggression with adaptive care techniques provided by a trained caregiver. So you can see here that we are using education by educating caregivers. Some of the adaptive techniques that might work for somebody like Ruth might be to give her increased time to process directions and information. You may also provide additional multisensory cues for her. So instead of just giving verbal directions, giving some additional visual cues or tactile cues. We might find that having her do this occupation in the environment that is natural for that task, like standing at the sink with the sound of water running, helps her to find that procedural memory and perform better compared to having her try to brush her teeth, like sitting in bed with an emesis basin. So again, we're looking at how can the environment and her lifelong routine of how she always brushed her teeth, how can that be used to support engagement? Another example, Mark is a 72-year-old cisgender male in early stage dementia who lives with his wife, who was a caregiver. And she was reporting that he was no longer engaging with his art. He had always, art had been a big part of his life. And he spent most of his time at the computer or following her around the house. And they were being seen by an OT through a dementia day program that he attended. And in that particular situation, he had this beautiful little kind of art barn out by the garage, and it had become just overwhelming. It was, he couldn't find things, the way things were organized. He had to open things up to find his supplies. So, working with the wife and him to put his supplies in a place that they were simple and, very accessible, really made a big difference. So the goal was client will engage in modified art activity with environmental modifications and visual cues to facilitate initiation and planning. And I'll actually, if we go to the next slide, show you a little sample of his tailored activity plan. And tailored activity programs or plans are a part of evidence-based practice. Laura Getlin's work over many years now has really supported the efficacy of this and other interventions for people with dementia that include the OT kind of scope of practice and skill set. But with a tailored activity program, it's a 3-phase program delivered by OTs in up to 8 60 to 90-minute sessions. And phase 1 is assessment, which includes that cognitive assessment and the occupational profile. Phase 2 includes intervention, focused on 3 goals that are selected by the person with dementia and their caregiver, and they learn to set up and cue and facilitate a meaningful activity. And then phase 3 is additional caregiver education and coaching on how to generalize the intervention to other types of activities. And the intervention that I provided in this case didn't strictly follow the tailored activity protocol, but it was certainly informed by this research and this work. I don't know, Sarah, would you be able to click on the link in the example there? Oh, shoot, I would have been able to. That's okay. Yeah. So anyway, there's an example there of the handout that we would create and provide for the family with directions on how to set up. He really did best when he just had very minimal supplies. He had a little cue card. The family had reported that he was spending a lot of time on the computer. He didn't really like to be told what to do. So she just put the little cue card there where he could see it to remind him to go to his art barn. And it was a very successful intervention. So I think that's about it for what I had to share with you. And I'm going to pass it back to Sarah.
Thank you, Gina. So we promised you 5 sort of top referrals that match the 4 M's of age-friendly health systems. So I'm going to do the last 3. The next one is mobility, which is probably the most overt or obvious one based on that is one of the 4 M's. But we're going to talk more about not just personal mobility, but that OTs work on what we call community mobility, and I can help define that more. So things like fall reduction and prevention, wheelchair management, and with that seating and positioning, fitting for wheelchairs, other mobility devices, use of public transportation or the process of stopping driving, and then driving. When it comes to mobility and older adults, almost every setting where an OT works, we're always going to be addressing mobility. So anything from acute care, skilled nursing facilities. I didn't list here what we call inpatient rehab facilities, but older adults do go to those as well. That's your more intensive rehab, maybe post-stroke. As Gina mentioned before, a lot of older adults go to skilled nursing facilities where they're still getting active rehab, but the intensity is lower because of many chronic conditions. Maybe it's not the first stroke, it's 2 or 3 in, and so lots of complicating factors. Outpatient. For OT and older adults, a lot of times if you refer someone to outpatient, it will be not, as Gina mentioned before, like for children or pediatrics, where there's a lot of private practice or sort of freestanding outpatient clinics. A lot of them are associated with larger hospitals or systems. And a lot of times, if you're going to make that referral, you'll see that there's sort of neuro outpatient and ortho outpatient. So kind of depending on what the need is. But there might be different areas of the clinic you might be referring to someone to. So home health, and remember home health with OT, that is, again, a very age-friendly thought of, it doesn't mean just your independent home. If you live in any residence that's your home, an assisted living, retirement living, an adult care home, then home health would come to you if you don't have the mobility to get to an outpatient clinic. And there's all kinds of community wellness programs that look at more maintenance and health promotion.
Sarah, there's a question about what would be a hospital-acquired disability?
Yeah, thank you. So looking on this, the right part of this slide, so we've covered rehabilitation. I think that's pretty obvious. Reducing hospital-acquired disability. This is a new term that's come out in the research lately, and they're finding particularly for older adults, even more significantly with older adults with dementia, people leave the hospital with less function than when they came in. So if you lose mobility because you're in acute care bed and you're not actively getting up, that would be a hospital-acquired disability. Delirium can be a hospital-acquired disability, bed sores, so really any loss of function. And I think everyone in this group is probably very aware that we have a healthcare crisis around this for older adults, particularly post-COVID, getting worse in that people come in for things like frequent falls to acute care, sepsis, failure to thrive. And then it becomes apparent that maybe a dementia or underlying other functional issues are the reason why someone brought them to the hospital, though they needed the acute care, and then discharge becomes very difficult. We have older adults that are sitting on acute care units. I know at least across the state of Oregon, for something that maybe should have been a 5 or 6 day stay, that are there for 90, 100 days because of the behaviors and nowhere to discharge. So those become hospital acquired disabilities. We look at mobility and everyday activities. Thinking about the difference between physical therapy and occupational therapy, because older adults may be seeing both professions, especially around mobility. The difference is defined in our scope of practice as, do you have the mobility to do things you need to do? Not how strong is your gait, how strong are your lower extremity muscles, what is your vestibular system like? Of course, we look at all that, but it's like, do you have the balance or the mobility, or can we adapt it so you have enough mobility to perform independent toileting? So mobility within the context of doing something else is where OTs treat a lot of mobility. Going past personal mobility, we work with people that can no longer drive and need to learn to understand how to ride public transportation or access other public services for transportation, managing maybe assistive technology around that. I don't know if anyone's tried to ride a bus lately, but there's very, very complicated apps that didn't exist too many years ago. Looking at overall mobility in the community, as in, do they have access to stores? Can people get there? Is that affecting their other self-care? One that I always sneak into mobility, especially in home health or more outpatient services, is a lot of times the community mobility they really want to do is to walk their pet. And what a good motivator, right? That's why people are up and walking. OTs can get very creative, right? Medicare doesn't consider pet care, a health necessity, but they do consider getting to the store, getting to the doctor a necessity. So we can work on other things. We can motivate our clients of, this will also help you be outside with your dog. And OTs are the only rehab specialists within their scope of practice that do driving evaluations and adaptive driving. So that's an important note. What kind of goals might we have around mobility? We have two situations here around mobility. So Diane is a 72-year-old cisgender female who lives alone in a single level home. She has recently been falling at night and is seen by home health occupational therapy. For an OT going in and seeing someone, particularly in home health, remember that person, occupation, environment model, immediately thinking, why is it particularly falling at night? Are there vision issues? Is it getting up to go to the bathroom, which actually is the most common reason older adults fall at night? So we might actually have a goal that's around toileting independence, but we have a lot of mobility built into that because the falls at night might be driven by urgency to use the restroom or difficulty getting there. Another example, Robert is a 64-year-old cisgender white man. He's lost his driver's license after a stroke. He lives in an urban apartment and wants to continue his recovery by attending swim class. So he'd like to get to swim class. He's seeing occupational therapists and outpatient clinic. So again, looking at a goal around being able to independently navigate public transportation to attend swim class. And you can see the holistic approach of OT. That looks pretty straightforward. Like you could give someone a sheet of directions, but we need to find out, where's the bus stop near Robert's house? Can he read the bus schedules? Does he have the cognitive skills to navigate or know what spot he's supposed to get off? So there's a lot of safety cognition that's being wrapped into mobility as well. Our next section is looking at aging in place for OT. So home safety and modifications. Aging in place is one of those terms that can be seen fairly broadly, but is most commonly explained in the literature as people not having to make multiple moves, that they can continue as they age, not to need higher levels of care. So how do OTs help with that? Again, falls are one of the number one reasons. Falls and incontinence are one of the number one reasons people go to more institutionalized care. Do they have, is their housing accessible? Is there stairs? Are there things they can change within that environment? Limiting environmental hazards. This is like the simple example of this is things like, you know, how messy is the home? Are there throw rugs everywhere? Are there trip hazards? Then overall being able to work with an older adult on improving household management skills. Are they cognitive and physically able to actually clean up their house? Or is that why people are saying things like they seem like a hoarder? And it's actually nothing to do with hoarding. It has to do with the actual management skills. And then what we call activities of daily living, instrumental activities of daily living. Those are all your household management, your med management. OTs will work on all those skills. So usually at home modifications, it can be recommended in outpatient. A lot comes through home health. There are some private practice opportunities. And then there's some community services that OTs might be working in, and we'll have an example in a minute. I think we touched on most of these. We talked about energy conservation. So are people exhausting themselves by trying to clean up really early in the morning and do self-care and then don't have any energy at night to finish anything that needs to be done? Gina touched on this a little bit, but this is really important for both aging in place as well as our next topic, which will be psychosocial and social participation issues. Med management, like I said, can you open the pill bottle? Can you lay out the pills? Do you understand how to take your pills? It's not about recommending any kind of pharmacology. A program I wanted to highlight, this is the Capable program, comes out of Johns Hopkins. It's an innovative, well-studied and evidence-based program. So I did put the links in if you want to look more into it. It becomes grant-funded generally, and it is a community-based service that takes an OT, an RN, and then somebody with like a contractor or a handyman, and they work all together. It's a 4 to 5 month program, and basically do an individualized plan for someone living at home that needs home modifications, setting goals, looking at routines, and then we have the person that actually can put the modifications in place. So it's a very holistic program. Something to think about with people you refer to OT, things like we'll do a lot of home modifications if we can do them with sort of our own little toolkits, like quick things to make things easier. When it comes to large things like installing grab bars, installing a ramp, that can be recommended by an OT for accessibility, but OTs don't get paid the person still needs to pay for those modifications to happen. So that can be a big challenge for accessibility for older adults. So this is an innovative practice that can, if you have a team in your state, that can help out with those issues. And it does really look at lowering healthcare costs. A lot of the evidence around it is quite interesting in the way of it's keeping people from being injured. It's keeping people safe. It's keeping people out of the hospital and out of higher levels of care. What kind of goals might we have? So again, here's a couple examples. We have Emily, who's living in her own home. She's a widow. She's seeing a home health due to decreased safety in the shower and challenges with med management. So looking at goals like they'll utilize their home modifications to bathe with what we call modified independence, sort of rehab speak, but you can do it independently with equipment, what that really means. We have Fred, who's living with his girlfriend in assisted living, Parkinson's. again, being seen by OT through home health because he's having a hard time with those IADLs, that home management, and also a fall risk. This situation looks at reducing the clutter in his home, removing environmental hazards, and identify placement for additional grab bars and safety equipment. I think about this one a lot because I've heard it so many times in my career that the OT comes in and tells me to clean up my house and put away all my knickknacks and pick up my rugs and just change in the house. So we need to go back to being very collaborative. I have 5 recommendations. Do you think you could do 3 that would improve? Which ones do you buy into? Because someone's home is a lot of time what matters to them. And so maybe they want all their 300 Dalmatian figurines all over the house. And that makes them happy. That's important. Well, then that's, take it off the list. Okay, can we change something else? So really listening and thinking about that. Those routines and patterns are so important. So here's a med management goal as well, putting pills in a pill box for independent management, or things like making sure someone can schedule and attend weekly appointments independently. They know how to get there. They know how to call a ride, those type of things. All right. I think we're pretty good on time. So this is our last one. So mental health and social participation. Occupational therapy actually was born out of the mental health space. Those are our oldest roots are in mental health. So you'll see a lot of this psychosocial functioning sort of underplaying almost everything that we do. So looking at, do people have physical function for activity participation? Are things accessible? Lifestyle management, or there's evidence, some very strong studies out around what we call lifestyle redesign. So what are these patterns and other things, and how can we look at those managements and those changing patterns and routines to manage health conditions more appropriately? Adapting activities for changes of function. And I put that one in there because that's sort of all of OT. But when I thought about mental health conditions in older adults, yes, we have people that we see with persistent mental health challenges. Gina talked earlier about neurocognitive changes that have neuropsychiatric behaviors like dementia. But a lot of things we see with older adults is grief and loss. Whether that's grief because you've had a stroke and your body no longer works the way it used to, whether it's the loss of a pet or a partner, loss of a driver's license. So those things have huge impacts on function from a mental health point of view. And I didn't really know where to put pain in this presentation, but I wanted to highlight that OTs work with non-pharmacological pain management techniques. So, I mean, I don't know there's anywhere in healthcare, you don't deal with psychosocial or mental health issues. So I basically listed everywhere I could think of where we see older adults. I did want to point out that a lot of OTs do work on geriatric psychiatry units because of their strong ability to do functional cognitive assessments, pairing mental health challenges with how it might be affecting self-care. So you will definitely see OTs on geriatric psychiatry units, and then in some pain clinics. Looking over, so remember, reintegrating the community after a hospitalization can be very challenging. Anyone that, I shouldn't say anyone, a lot of older adults that have mental health challenges will have quite complicated med management routines that they need to manage. And again, lots and lots of caregiver education. So a few more examples. We have Ben, who's living with his partner. He's lived with bipolar disorder. And as he's aging, his manic episodes are not being controlled as well. He sees an occupational therapist in geriatric psychiatry. who does a functional evaluation and looks at interventions for med management, social participation, and lifestyle management. What's changing that these things are becoming more frequent? What are the challenges when he has a manic episode to his function? So a in hospital or in treatment for a mental health goal might look like something like they're going to participate in 75% of structure group activity with no more than a certain amount of cues. Maybe anxiety is not going to interfere with self-care. And then looking at independence and participation in so many leisure activities weekly. This last one is Carla, seeing OT sort of in a traditional way, post rehabilitation, now an outpatient, post stroke, but she's a widow, she's lost independence, and she really also, beyond just working on fine motor control, the OT is going to be working on things like increasing social participation and probably managing pain in her hemiplegic shoulder. Here's our references. I didn't put on here, but I wanted to say that all our images were free to use off a free to use site, but I did not cite the images on this last page.
So
And I go ahead.
this has just been great. Everybody's sort of chatting in about how incredibly helpful this has been to acquaint us with the scope of practice with occupational therapy. If you're out in the community, what are your suggestions for making referrals for occupational therapy? You know, like how would a person working in a community agency who thinks this might be really helpful, do you have a sense of how they might make a referral to an occupational therapist to help?
Yeah, and things vary by state, so it depends on what state you work in, but generally, a Medicare-driven system, you're going to, for more traditional areas of practice, so our inpatient, outpatient, those things, you're going to go through a primary care for a referral. So I think it's learning, and usually they're really easy to make. The doctor just doesn't know what to write for. So making a referral to home health for safety and fall reduction or whatever it might be. So letting them know what they're writing for so they get to the right OT. Any thoughts on that, Gina?
Well, I was just thinking about if it's home health, there kind of needs to be a broader, medical issue. So if it's more targeted, like, more on the health maintenance side, the managing chronic conditions, the psychosocial side, you might be better to go through an outpatient clinic because those clients may not really qualify, they may not have the medical complexity and need for home health. So outpatient might be a better route, or, this is a little beyond just the practitioner in the community who wants to make a referral, but I think continuing to advocate for OTs to be in community-based organizations that serve folks from a more preventative framework or preventative model is really, really helpful. I know the example I shared with the dementia client, I had HRSA funding through my Geriatric Academic Career Award and was had fieldwork students and was providing services at our Sonoma County Council on Aging, and we were partnering with the day program and enriching people's ability to participate in day programming, and then also pushing into the home to do those consultations and interventions in the home with the people who went to the day program with their caregivers in the home. So, if we can get people who make those decisions about, what to fund in community-based organizations, I think there's just a tremendous amount that we can offer to that.
That's great. Somewhat related to those sorts of dilemmas is a question about, are many of the OT services paid for by Medicare or Medicaid? Do they require referrals from like the primary care provider?
Yeah, most everything we covered today is, that we can bill that under our CPT codes under Medicare. There are OTs who have always worked in a very traditional medical model realm that may be a little bit uncertain about how to document and how to demonstrate their skill in some of these areas that are a little bit more on the mental health side if they don't work in a mental health setting. So because our scope is so broad, sometimes you will find the OT that you find in your community doesn't have that particular skill set. And so that's a frustration, I think, sometimes. But yes, these are all, billable Medicare services.
The only one I'd say to, and there's some workarounds, but driving is not paid for. Driving rehab is not paid for by Medicare. They don't think it's medically necessary to drive. So sometimes someone will be referred for like a functional cognitive evaluation by an OT, an outpatient, but they're kind of like peeking at those skills to see if driving should be on the table or be taken off the table. So that's, and then home modifications, like I said, I want to clarify, unless it's a grant funded project, that the information or the consult's paid, but not actually getting the modifications done to the home. Medicare doesn't pay for that.
I'm happy to see in the chat that the Full Life Care sounds like is a community-based organization that offers OT services in Snohomish. Is that how you say it? Snohomish County?
Snohomish, yeah.
Snohomish.
They're a great group. They're actually kind of in various parts of Washington State, but a great group. Nikki had mentioned that the skills demonstrated by occupational therapists really need to be promoted. She said that she's seen excellent results by OTs in a variety of medical and age behavioral situations. They are valuable members of the healthcare teams. So my question is, any other suggestions or thoughts about how we can spread the word or encourage those kinds of referrals?
Yeah. Thank you. Such a very true comment and commentary. That was really the whole focus of my GACA, was to try to get OT, and it's difficult. There aren't as many of us out there. I would say in some of the interprofessional spaces like Gerontologic Society of America and AGS, that you won't see very many. OT doesn't have a large presence there. So I think, in pulling OTs in, if they're not already at the table and they're busy in their clinic doing rehab and they don't know that they really have permission in your setting to, permission is, an unfortunate choice of word, I guess, but that they're invited to be part of these bigger issues, that you tap them and ask them, if they would be willing to be involved. Many times I do a lot of work with skilled nursing facilities, and they won't be involved in the behavior committee or the discussions about psychotropic medications, and they certainly should be, but maybe they're in the rehab gym doing all of the post-acute rehab for people, and they're not really involved in the long-term care side or the behavior management side. So I think it's just now that you know, just reaching out to the OTs that you work with and say, hey, how can you contribute to these issues that we're having or these problems?
And Mary is wondering, how do you find an OT practice maybe that does do the driver evals? Do you have thoughts on that?
I'll see if Sarah has anything on that. If not, I have I know somebody who's like somebody put up. Yeah. Okay.
Yeah, and you'll see if they are people that they're OTs, but then they get another certification, so they can actually do the on the road testing. They can actually, like post stroke, you can go through driver rehab and then you can get your license back, like post stroke. We also do it for older adults that are just aging and maybe have considerations. It's a certified driving rehab specialist, so CDRS. They must have a registry or an association, but it's I know we only have 3 in Oregon, so it's not and then they have some clinics that are outpatient that they might do, like the VA has their own separate program. So kind of depends on the system you're in.
And thanks, Mary Pat, for mentioning the Capable program. Let's see. And Stacy, thanks for introducing yourself from Full Life Care. How do you get an older adult who really should be using a walking aid to use a walker or cane when they refuse to do so for a variety of reasons? Maybe find it cumbersome or difficult to use, or pride or stigma. Any thoughts about how you encourage that use?
Yeah. So one thing that comes to mind that I've experienced quite a lot with when working with people with dementia, is that sometimes it's the problem solving to maneuver and be able to use that in the difficult space. And even in the earliest stages of dementia, when it's not real obvious, there's a lot of impairment in problem solving. And people will tend to still want to get the job done, and they'll want to complete the tasks that they're working on, and they'll just kind of bypass whatever the problem is. So they will leave the walker behind and, keep on going. So you might look at how could you simplify the space and make it easier for them to use it, or would a grab bar be a more intuitive, or a transfer pole be a more intuitive physical assist if it's a very small space? There's many different reasons why that can come up. I mean, you mentioned the stigma, kind of values around that. So I think that's where you'd really want to dig in and have that full occupational profile to see how is the context and their values, coming into play. I don't know, Sarah, any other examples that come to mind for you?
Yeah, just right about what you kind of ended on. I was thinking that if it's a cognitive issue, then we have we look more at the environment, how to simplify it. But if it's more of, like I said, a motivation, stigma, another reason, I find the most motivating thing is what matters. So, what are they missing out on by not using the walking aid? So can we make goals like, what if you did this, you know what I mean? Like, I have some great adaptations for, the dog leash on your 4-wheel walker. Let's figure out how, what to do, and get people's buy-in. Because just giving people equipment or telling them to do something, I mean, I'm stubborn enough, and if you've been doing something this, for 75 years a certain way, it's like you have a reason why you want to do that. So you just get that motivational interviewing and that occupational profile of how's this going to help your life.
So I have a sort of a slightly different question, but I'm wondering, what would you call it, the pipeline for people going into occupational therapy? Where could we, when we're wanting to encourage people to go into occupational therapy, identify, groups that might be interested and so should be encouraged?
Yeah.
What's within your profession that you're, targeting certain groups to encourage that consideration?
Yeah. I know when I do outreach to people who maybe haven't heard about OT, or who fully, don't understand it, I really talk about the holistic nature of our practice. And, you'll see prerequisites for most OT programs are about equally weighted, with psychology courses and then the anatomy and physiology. And that was really what was attractive to me, was that, holistic perspective. And so I try to really help people understand that that is a big part of who we are as a profession, and the problem solving, part of what we do. We really are professional problem solvers that try to have a whole lot of information, the biggest circle of information we can have about a situation in an individual. So if that is something that somebody really enjoys, we have right now 2 ways to enter the profession to have the education that you need to sit for our exam, is either a master's degree or an entry-level doctoral degree. So students can choose either of those paths. And the entry-level doctoral degree, potentially opens up some additional opportunities for education and research and innovation and leadership. And then we have OT assistants in our profession as well that can enter the profession of being an OT assistant with 2 years of training, generally either at a community college level or a bachelor's degree level. So, yeah.
This
Sarah,
has
you want
just
to add
been
anything?
great. Thank you so much. Really have learned a lot, and I think you could see from the chat that everyone agrees. This was important for us to know. So
Thank
thanks
you.
for the presentation. The recording will be posted probably within the next 24 hours. Oh, is there OT in other countries? If
Oh,
yes, how does that look
Absolutely.
like in comparison to the US?
oh, thank
Yeah, there's really yeah, strong OTs, Australia, Europe, Canada, India has a very strong OT presence, Japan. So definitely, the entry level and the licensure looks different. So like the board certification exam is different in other countries. But I know even in our program, about 25% of our students actually do international field work. So we definitely, we're out there, believe it
Well,
or
that
not.
would be so interesting to do international field work.
yeah.
Wow. Yeah.
I do think that OTs in many other countries tend to practice. They're a little further down the road than we are, I think, at practicing at a population level or at an organizational or group level, where because we've so long been our reimbursement has been tied to the medical model. And that has required that you show, medical necessity and improvement. And that's limited a little bit of where we've gone, where countries maybe that have, a more expansive reimbursement system, OTs seem to have opened up and developed that part of their practice a little bit more in the community. Yeah.
Definitely, I would say, and a lot of for older adults, healthcare systems that are more inclusive and getting away from and OTs having hands, and our long-term care system is modeled after hospitals, right? A nursing home's modeled after a hospital, whereas you have things like the dementia villages in Europe, which I'm going to next week. I'm so excited. Gotta share that. But yeah, so just very much more for older adults looking at quality of life versus our safety and quantity that we tend to focus on too much in the US, from my OT opinion.
Yeah.
So,
Well,
quality.
great. Maybe you can come back and tell us all about it.
I will. I'll give you a little slideshow.
Yeah. All right, everyone. We'll see you next
Thank
week.
you.
Thank
For attending,
you.
and thanks for the talk. Just great.
Thank you so much.